Hello everyone, welcome to ACE Anesthesia. Today's video will be discussing about double lumen tubes and bronchial blockers. So first we'll start with double lumen tubes. We'll be discussing what are the indications of one lung ventilation, which includes for both double lumen tube and bronchial blockers. What are the contraindications of a single lung ventilation? What is the basic design of a double lumen tube? What is the selection of, how do we select the appropriate size of double lumen tube for a particular person? And we will see what is the technique of insertion of a double lumen tube, and also what are some of the complications which is affiliated with the double lumen tubes. And at the end of the first portion of this video, we'll be talking about certain brief details about the double lumen tubes of various types. Okay, so double lumen tube, this was first discovered by person called as Carlins. Okay, so he was the first person who discovered the double lumen tube. So coming to what is the indications of a one lung ventilation. So indications of one lung ventilation can have the following purposes. First is to protect the contralateral lung. So this is in conditions like the contralateral lung which is having any lung abscess, or there is any pulmonary hemorrhage or any lung infections. In that case, to protect the contralateral lungs, we can do a one lung ventilation. Another indication is a bronchopleural fistula. Right, this is another indication of one lung ventilation. And third is to have a good surgical exposure. This is in conditions of surgeries, like in case of video assisted thoracoscopic surgeries, or in surgeries like esophageal surgeries or minimum invasive cardiac surgeries, or other lung surgeries like lobectomies and pneumonectomies. Okay, so these are the indications of a one lung ventilation. Now coming to contraindications of one lung ventilation. In contraindications, we have absolute contraindication that includes any tumor or a mass that is present in the carina or main stem bronchus. Okay, so in that case, the one lung ventilation is contraindicated. Another relative contraindication may be a patient with a difficult airway, or in patient with a full stomach which will require a rapid sequence induction, or it can be patients who require both the lungs to have proper oxygenation, are relative contraindications of one lung ventilation, right? So coming to next, we will be seeing the basic design of a double lumen tube. So all this, let me tell that all the double lumen tubes which are present, they have a basic design which is based on the Carlins tube, which was the initial double lumen tube that was discovered. Okay. So now I'll be telling just the brief design of common to many of the double lumen tubes. So most of the double lumen tube will have a cross section in the form of an ellipsoid. Okay, the ellipsoid cross section will be present, and it will have a septum. So there are two D shape. So this will be vertical, horizontal, and this one all will be changing in various types of double lumen tubes. So I'm just telling the basic structure. It will be ellipsoid with a septum that is present. So so what happens that this septum will ensure that there is adequate oxygenation and there is actually adequate airflow without much of turbulence. So there will be this septum, as well as we will be having an ellipsoid structure. One will be opening in the trachea and one will be opening in the main stem bronchus, to which the side of the double lumen tube belongs. Okay, so one opening in the double lumen tube will be in the trachea. Mostly it will be ventilating either both the lungs or one side of the lung which we want to be ventilated, and the other side opening will be in the distal main stem bronchus. Okay, there will be two cuffs. There will be a tracheal cuff and a bronchial cuff. Okay, tracheal cuff that is present will be mostly in the distal end of the trachea, whereas a bronchial cuff which will be present in one of the bronchial lumens which is extending. Okay, so there are two cuffs, and each of these tubes will be having a 15 mm. The tube will be proximally having two 15 mm ET tube adapters. Okay, they will be helping connecting it to the ventilator. So this ET tube adapters will be then connecting to a Y shape. So there will be one for the each lumen, that is each septum, and they will be in turn connecting it to the ventilator circuit. So this is how the endotracheal tube basic design of a double lumen tube is present. Okay. Now coming to how do we select the size of a double lumen tube. So the double lumen tube that is present, usually the sizes can be selected based on the age of the patient and the sex of the patient. Another method of selection is based on the tracheal width, which we see on an X-ray, and an advanced method which is present is based on the CT scan. So based on the age and sex of the patient, right? So I'll tell you one technique how to remember. One may be for males, one may be for females. Okay, and based on the this is age that is present. Sorry, not age. This is the sex of the patient and then height of the patient. So less than 160 centimeter, 160 to 170, and more than 170 centimeter. So it will be a difference of 2. So males it will be 41, females 39, 39, 37, 37, 35, right? So this box can be easily remembered this way. This will be the sizes of the DLTs which we commonly use based on the sex and the height of the patient. 8 to 10 years, it is size number 26. 10 to 12 years, it will be 26 to 28, it may vary. 12 to 14 years, it may be around 30, right? And 14 to 16 years, it may be around 32 to, sorry, it may be around 32, and here it may be around 32 to 35. So approximate size of the DLTs in pediatric age group, it can be based on this, right? So another method which we also identify for the size of the DLT is based on the tracheal width. So how do we measure the tracheal width? Right? Tracheal width is basically measured in the chest X-ray at the level of the medial end of the clavicles. So this will be measuring the tracheal width. Okay. So tracheal width and the size of the DLT are also related. Based on the tracheal width to the DLT size, okay, how do we decide it? If the tracheal width is more than or equal to 18, DLT size will be 41. If it is more than or equal to 16, DLT size will be 39. More than or equal to 15, it will be 37. Or more than or equal to 14, it will be 35. So this is another technique how we can determine the size of the DLT. So one more important thing which we should know is the depth of insertion of the double lumen tube. Okay, the depth of insertion of a double lumen tube will be height in centimeter divided by 10 plus 12. That will be the depth of insertion of a double lumen tube. So one more thing which you all should know is what will be the bronchial width. Okay, so bronchial width, based on which through the CT scan we identify the size of the DLT, is approximately, there is a formula which is 0.4 into the tracheal width plus 3.3. So this is the formula for the bronchial width to determine the size of a double lumen tube. So after this, we will be seeing about the technique of insertion of a double lumen tube. So before inserting the double lumen tube, we should always perform a check. That is, we have to inflate both the cuffs of the tracheal as well as the bronchial lumen, check for any leaks that is present in the DLT. We should also ensure that the slit is inserted into the double lumen tube and it should not be protruding out of the bronchial end of the double lumen tube too much outside, otherwise it causes airway trauma. Right? Good lubrication has to be applied, and also we have to check for the volumes the cuff gets maximally inflated to, and also we have to check for the leaks or any external damages. Right? So after this, how do we insert the double lumen tube? A laryngoscopy is performed by the standard technique, pushing the tongue from the right to left. We visualize the glottis and the double lumen tube is inserted along with the stylet. Okay, with a curve of the bronchial side facing front itself. Okay, once you insert it and then the double lumen tube passes across the glottis, that is, once the tip of the DLT passes across the glottis, you can remove the stylet and push it forward till you reach the tracheal cuff. Once the tracheal cuff passes across the glottis, you rotate the DLT by 90 degree to the side on which you want to have the bronchial end of the DLT to be present. Okay, so if you are now inserting a left-sided DLT, we insert the glottis. Okay, once it reaches across the glottis, the tracheal cuff, we remove the stylet, rotate it to the left by 90 degrees. Once you reach that position, you will feel some kind of resistance till it touches, and then we can connect it to the ventilator. Right, so often it may happen that it continuously goes to the opposite side. That is, if it is a left side or DLT, it may go to right bronchus often. So in that case, we can perform what is called as a Brodsky's maneuver or head turn maneuver. You can turn the head to the side in which it is going. That is, if it is going to the right side, you can turn the head to the right side, and then it in turn helps in putting the left sided DLT to the left main bronchus. Okay. So after this, we have to inflate both the tracheal as well as the bronchial lumen. The tracheal cuff is inflated to approximately usually about 15 to 20 ml of air, and the bronchial up to 3 to 5 ml of air. Okay, this is a usual ml which is given in a standard DLT. It may vary, and it is usually specified in the back side of the DLT wrappers. So you can read the how much ml of air to be inflated accordingly. Okay. Right, so once you have inserted the double lumen tube, how do we confirm the position of the double lumen tube? Right, position can be confirmed by our standard method, that is auscultation of the chest of the patient, which is usually for any tube or any airway device. When we insert, we see for the chest for auscultation. Second is the radiographic method. Okay, that is another method by using an X-ray or radiographic markers which are present in the double lumen tube that help us to ascertain the position of a DLT. Okay. So by auscultation, how do we know the position of the DLT? Number one is first we inflate the tracheal cuff. Okay. Tracheal cuff is inflated, and we will see for the air entry in the bilateral chest fields, and we'll also see the peak airway pressure. Okay, this is the step one. After doing that, number two step will be, we have to clamp the tracheal cuff. Okay, once the tracheal cuff is clamped, we have to open out the Y-shaped connector to the atmosphere, and we ventilate the lungs through the bronchial lumen. So before doing this, we have to inflate the bronchial cuff, look for the rise in the peak airway pressure, and look for the lung isolation. Right, so once you inflate the bronchial cuff, we have to ensure that peak airway pressure doesn't increase too much. Maximum allowable will be about peak pressure of about 40. Right, and also usually it shouldn't rise more than 10 of our baseline 2-lung ventilation. Okay, so once you inflate the bronchial cuff, you clamp the tracheal cuff and proximally open and vent it to atmosphere. You now look for the 1-lung ventilation, that is the isolated lung. Okay, after which what you can do is that you can release the clamp and there will be a 2-lung ventilation, and again you can clamp the opposite side and you can check for isolation of the opposite side of the lung. Right, so this is one way of checking whether the 1-lung ventilation is proper. Another is using the radiographic method, that is using a chest X-ray. Radiographic markers are present especially at the tracheal end as well as at the bronchial end of the DLT. Right. So so this bronchial end of the DLT that is present will be having a marker which is about 1 centimeter from the distal end of the left bronchus. So if it is a left DLT, it will be having a marker which is present at the left side of the DLT, that is the bronchial lumen that is going. So in this way we will be able to identify using a chest X-ray. And third way of identify is using a fiber scope, that is fiber optic bronchoscope. So first in this what we do, we insert the fiber optic bronchoscope through the tracheal lumen. Okay, we should be able to see the inflated blue cuff of the bronchial lumen, which is just beyond the carina. Okay, we have to ensure that the blue color bronchial cuff is not protruding into the carina or not very far into the distal bronchus. Okay, once you reach through the tracheal lumen, you have to enter into the right bronchus, look for right upper lobe, right middle and lower lobe, that is the bronchus intermedius is checked, and then we come out. Once then after this, we enter through the bronchial lumen of the DLT and we look for the position of the bronchial. So we have checked in by going through the tracheal lumen, we have checked the position of the blue color balloon that is present of the bronchial cuff. Okay, so bronchial cuff, once it's checked, we have to next look for the patency of the bronchial side of the DLT. So we pass through the bronchial lumen and look for the left upper lobe and left lower lobe opening. Right, so this is how we can check the position of a double lumen tube using the fiber optic bronchoscope. Why? What are some of the complications of a double lumen tube? So number one, there may be malposition of the double lumen tube that can occur during the change in the position of the patient, that is either lateral if we pose. There are increased chances of malposition. Number two, it causes extensive airway trauma, right? So because of its huge size as well as its kind of the structure it is made up of, it causes lot of airway trauma, right? And it is also very difficult to ascertain the correct size of a patient, even though we saw some of the methods to identify the approximate size. Often it may not work out for certain patients. So if it's very huge tubes, it may cause lot of airway trauma. Right. Another cause it may is that it may cause hypoxia in certain patients, right? Because of any malposition of the tube, or it may be also because of the displacement of the cuff. Often the bronchial cuff may get herniated into the carina and cause hypoxia, right? And another features is tension pneumothorax. So these are some of the complications which are often associated with a double lumen tube. But what are the advantages of a double lumen tube over a bronchial blocker? If we see the double lumen tube advantages over a bronchial blocker, number one is the ease of insertion, right? Okay, and also it does not require a fiber optic bronchoscope, right? Another thing which is present in a DLT is that you can change the side of one lung ventilation. So this cannot be done in a bronchial blocker. Okay, that is, it can be done, but the process will be very slow. So, but in a DLT, the change in the one lung ventilation will also be fast, because you can also suction both the lungs using the DLT, right? Another thing which is present with the DLT, what is the advantage is that you can also provide CPAP to the lung using a double lumen tube, right? So these are the advantages. So the disadvantages, as we read, it is easily malposition and it also causes lot of airway trauma. And another thing is that whenever you are finishing the case, you have to shift it to a single lumen tube, right? So this is easy with the bronchial blockers, but in case of a double lumen tube, we have to shift it. But in a bronchial blocker, you just have to remove the blocker and then already a single lumen endotracheal tube is present in C2. So next we'll be seeing the brief features of the various types of the double lumen tube, starting with the classic Carlin's double lumen tube. This was one of the first tubes that was used. It was made up of red rubber, and the classical feature of a Carlin's double lumen tube is the presence of a carinal hook. Okay, So this double lumen tube that was present, it was basically a left-sided double lumen tube, as you can see. So the left side of the bronchial lumen will be forming an angle of about 45 degree with the main stem of the double lumen tube. Okay, so one of the advantage of having this Carlin's double lumen tube is that it can be inserted even in a pulmonary hemorrhage where the vision is not very good based on the because we had the coronal hook that will help us to identify that it is sitting in the right place, right? So it also had two cuffs. One was for the central tracheal cuff, and then we had the bronchial cuff that was present in the Carlin's tube. This is a left-sided tube. The Carlin's tube basically had a cross-section area in the form of an ellipsoid, okay, with a septum. But a right-sided version of it, often called as right-sided Carlin's tube version, is also called as the White's double lumen tube. Okay. So next, coming to Robert Shaw's double lumen tube. Robert Shaw double lumen tube was also made up of red rubber. So the Robert Shaw's double lumen tube was available both as a right-sided plus left-sided tube. Right, so right-sided tube which was present, that forms an angle of about 45 degree, and left-sided formed an angle of about 20 degree, right, approximately. So in a Robert Shaw double lumen tube looks somewhat like this on a gross scale. So there is a central tracheal with a tracheal cuff that is present. Okay, this was the lumen for the central tracheal ventilation. Okay, for the tracheal lumen. Okay, this was the bronchial cuff with a bronchial lumen. So Robert Shaw tube also had two inflation tubes with pilot balloons, one for the central tracheal cuff and second for the bronchial lumen that was present. Okay, so this was the Robert Shaw's double lumen tube. Next we come to bronchocath, which is the Portex double lumen tube which we use in the present day most often. So this consists of basically a central tracheal lumen with a tracheal cuff. There is a slot for the ventilation for the tracheal lumen. Then we have a radiographic marker which will help us to identify. So this picture which I have drawn is a left-sided double lumen tube. We also have a right-sided bronchocath double lumen tube. So left-sided tube, which we notice that the cuff will also be blue in color with a blue color tubing connector as well as blue color pilot balloon with the inflation line. So this will help us to identify the bronchial site with its with its balloon, right? So this is the central tracheal lumen with the cuff. There is the port for the common ventilation. There is a radiographic marker that helps us to identify, as I said, the position of a double lumen tube. Then we have the bronchial cuff with a bronchial lumen. So this side which I have drawn is a right-sided DLT for the bronchocath. So here one additional feature that will be present is support that is present distal to the bronchial cuff for the right upper lobe ventilation. Right, so this is present in a right-sided bronchocath, and this is most commonly a left-sided bronchocath. So the second part of this video will be discussing about bronchial blockers. So these are also the devices which are used for achieving a single lung ventilation. So this is passed through a standard single lumen endotracheal tube and used to obstruct the ventilation of a one particular lung. Okay, so the single lumen, so this bronchial blocker that is present, the basic design is that it is inserted through a single lumen tube, and then it contains basically, the basic design has a blocker with a cuff, right, with a port for the distal tube or suctioning, and also an inflation line with a pilot balloon for inflating this cuff that is present of the bronchial blocker, right. So this is usually inserted into the lumen, or it can be also inserted by the side of the single lumen endotracheal tubes. Right, coming to the basic design, as I said, it contains like a small lumen with a cuff with a pilot balloon or an inflation line that is used to inflate the cuff. The cuff is usually low volume, high pressure cuff that is present. Coming to the indications of a bronchial blocker, Like in case of a double lumen tube, it is used for those conditions which require a single lung ventilation. But it is more useful in patients which are having anticipated difficult airway where insertion of a DLT becomes difficult. It is also used in patients who are having already an endotracheal tube. So it is very easy to just insert the bronchial blocker through it. Okay. And one more thing is that it is also used for achieving in surgeries which are not very much requiring complete very good lung collapsing, that is like in case of lobectomies or pneumonectomies. So it can be also used in surgeries like esophageal surgeries, minimum invasive cardiac surgeries, or it can also be used in spine surgeries with anterior approach. So these are the uses which we use for the bronchial blocker. Next, coming to the advantages of a bronchial blocker. Advantages is number one is that you don't have to determine the size of a bronchial blocker. So for an adult, most common size are size 7, 8 or 9 mm is available, and most of the time the size doesn't matter much while inserting a bronchial blocker. And second is it barely causes any airway trauma, because as already an endotracheal tube is present, we just insert it through the lumen of this endotracheal tube and inflate the cuff to the appropriate bronchial side, right? So another thing which we see with this, that it's quite easy to manipulate, and also the bronchial blocker that is present also gives a good view after the inflation of the cuff. But a disadvantage of a bronchial blocker is that it is very easily, it can be dislodged, right? One of the things is that. Another thing is that it doesn't provide a very good vision or very good vision compared to that of a double lumen tube in case of, especially in cases of lung surgeries like lobectomies or pneumonectomies, where it's very important to collapse the lung which is involved. Another thing is that especially with the right upper lobe, ventilation becomes kind of tricky while using a bronchial blocker, but this is not a problem in case of a double lumen tube. Also, suctioning of the lungs also is difficult in using a bronchial blocker, and also it's not very easy to change the sides of the lung ventilation, that is as compared to a double lumen tube in case of a bronchial blocker, right? So these are some of the disadvantages which we often see with the bronchial blockers also. So after we discussed all this, we'll be next saying about the various types of the bronchial blockers that are commercially available. So coming to the types of the bronchial blockers which are commercially available, first is the univent blocker. So as you can see in this diagram, it briefly shows how a univent blocker will look like. So it contains, it comes with a single lumen endotracheal tube that is present, which is made up of silicon. Okay, so the ET tube that is present will be coming along with this bronchial blocker as a set in a univent bronchial blocker. So this silicon tube that is present, it contains an inbuilt channel that is present on the concave side of the tube itself. There is a small channel for the passage of this bronchial blocker. Okay, so basically this univent blocker contains one main channel for the tracheal lumen for the passage of the gases, and it contains a smaller channel for the passage of the bronchial blocker that is present. So the bronchial blocker, that is the bronchial blocker is basically the distal tip of the blocker will be radio opaque. It contains its own cuff, which is actually a low volume high pressure cuff with a pilot balloon and an inflation line of its own, right? So whenever we are putting this bronchial blocker, we use a fiber optic bronchoscope through the tracheal side of the ventilation, that is through the main lumen, and we used to position this for the one lung ventilation. Okay, so one thing we also noticed that there is also a tracheal cuff for the single lumen ET tube that is coming with it, along with its inflation line with a balloon that is present, pilot balloon that is there. Also, the usually after placing of this bronchial blocker in this univent tube, we have to note the position, and it is actually manipulated by using a torque at the distal end. and it can be fixed in place with the help of a fixator that comes along with it. Right, and there will be usually a bend at the distal portion of the bronchial blocker for guiding it easily. So these are the basic characteristics of a univent bronchial blocker. Okay, next we are coming to Arndt bronchial blocker. So this was manufactured by Cooks. Okay, so this bronchial blocker that is present, it has a special characteristic that it contains like a blocker with a nylon wire that comes along with it. Okay, it also has a set of the four-sided adapter that usually comes with it. So in case of an Arndt bronchial blocker, how do we use it basically? So this Arndt bronchial blocker that is present, as I said, it is made up of a cuff which is actually low volume. It is made up of a cuff that is actually low pressure cuff comparatively. So this nylon wire that is present will actually help in guiding this with the help of a fiber optic bronchoscope guidance. So first we have to intubate this patient using the single lumen endotracheal tube. So after we do that, we can pass this bronchial blocker through the endotracheal tube. First we have to position this nylon wire along with the FOB, and we have to guide this blocker into the tracheal lumen. Once it reaches into the main carina, we have to guide it into the bronchus which we want to pass the blocker into. Right, once we reach that position, we have to distally push the bronchial blocker further and slowly withdraw the fiberscope till we are able to visualize the bronchial blocker. Right, so once it is in place and we are sure, we inflate the bronchial blocker and look for the position of the cuff and the main stem bronchus. Once we are satisfied with that, we have to remove this nylon guide wire that comes with it, and we have to fix the bronchial blocker in place. Right, so once after doing that, we can inflate the tracheal cuff and continue with our ventilation after attaching it to the adapter. So this Arndt bronchial blocker comes with a multi-port adapter. As we see, this angulated portion will be for the bronchial blocker. One lumen will be for the fiber optic bronchoscope or the fiber optic bronchoscope which we are introducing. One is for connecting to the endotracheal tube, and another is for connecting it to the ventilator circuit. So this adapter usually comes along with our Arndt bronchial blocker. Right, so but we have to be very careful because it's very difficult to reposition this blocker once the nylon wire is removed. So next we'll be coming to Cohen's flexi-tip bronchial blocker and EZ bronchial blocker. So Cohen's flexi-tip, it was manufactured by Cook's Critical Care. The important thing about this, it was about 65 centimeter in length and used to come in 9 mm size. Okay, so the classic feature is that it contains a distal cuff which was actually blue in color. There were some ports which are present distal to that of the tip of the bronchial blocker, and the cuff that was used for deflation of the lungs, that is the gas to get deflated from the bronchial blocker side. Okay, there was also a radio opaque marker that was present proximal to that of the blocker cuff. Right, so on the proximal end, we had what we called as a wheel turning device. Right, so entire the bronchial tip or the flexi tip could be angled to more than 90 degrees using this wheel turning device. So once we insert it through the single lumen tube, we can turn the tip of the Cohen's flexi tip. It was angled to some extent. We can turn it to more than 90 degrees and we can position it in place. Right, so and also once it is set in position, it is locked in position using a locker. There were depths of insertion of this bronchial blocker which can be noted, and it is locked in place. Right, so this was the Cohen's flexi tip. Another type which we use very commonly nowadays is the EZ blocker, which is also very easy to position compared to that of our other bronchial blockers. So like this is also inserted as shown in the figure via a single lumen endotracheal tube. So basically it contains like a Y shape with 2 cuffs and 2 pilot balloons and inflation lines that is present only in the blocker itself. So once we put the patient to a single lumen endotracheal tube, ventilate the patient. Then under bronchoscopic guidance, we can put the EZ blocker in place till we reach the carina. Right, this Y shape. So we have to ensure which side we are putting which colored inflation tube. Right, so one that is inflation balloon is present in which side. So usually in an EZ blocker, it contains two colored of different balloons. One is blue color, other is yellow color, and same colored pilot balloons with inflation lines will be present. So once you put it in position, the carina, it rests on this carina. We can inflate the balloon of the side which has to be blocked under fiber optic guidance. We see for the collapsibility of the lung, and then we take out the bronchoscope. So in an EZ blocker, usually it is made up of polyurethane. It comes with a multi-port adapter, right? So the multi-port adapter, which usually comes with this, one end connects to the endotracheal tube that is present, right? One end is through which the bronchial blocker is inserted, and the other end is used for a fiber optic guidance. So once this is over, you can connect it to the ventilating setup and ventilate the one lung ventilation. We have come to the end of this video. We have discussed about the double lumen tubes. We have seen also about the bronchial blockers. So I hope this video was useful. Please let me know if you need any topics to be discussed. Thank you.